All right. So we'll start with some of the questions about pancreatic neuroendocrine, and these are for both Dr. Maluccio and for Dr. Rose. The first question is, how common is it to see a pancreatic tumor in the middle of the pancreas, not by the head or the tail?
As far as giving you a percent, I don't think I could make one up, but I don't have one that's from a study or anything. I mean, it's not uncommon. They develop anywhere along the pancreas. Functional tumors, depending on the subtype, can be on one side or the other. But I think if you look at them as a group, it's a pretty even spread. The operation to remove it can fit in a number of different categories. It could be an enucleation if it's an insulinoma. And for me, it could be a Whipple, it could be a distal. There is something called a central pancreatectomy that I don't do, but some people do.
Yeah, it's the location in the neck or the proximal body is problematic. And I think that we are then more likely to push the watchful waiting for tumors that are almost less than 3 centimeters. Because a central pancreatectomy, I agree. I have stopped doing them. I think that they are have a much higher complication rate and winds up being a trade-off of one problem for another problem. But to take then the entire body and tail of the pancreas right up to the neck leaves you a much higher likelihood of becoming diabetic and exocrine insufficiency, and you're popping enzymes all the time. And the extended Whipple leaves you with a really small duct. And so it is problematic. And so I think that that is one where the decision for surgery is a lot harder. Maybe that's why you put the question on there. And they're probably putting the brakes on for aggressive surgical management.
Thank you. Dr. Chauhan, this question is for you. Can you hear me okay?
Yes.
Okay.
Thank you.
But he's there too.
Oh.
If you don't want to hurt your
Yes. The question is a grade 1 PNET a good candidate for PRRT? And how common is it to see bone metastasis from pancreatic neuroendocrine tumors, grade 1?
Great. Thank you, Dr. Gupta. Great question. So it's not easy just with that limited amount of information to say whether a patient is a good candidate for PRRT. But yes, for sure, PRRT is now approved for not just pancreatic, but gastroenteropancreatic neuroendocrine tumors, grade 1 and grade 2. And not only grade 2, as I mentioned in letter 2, we can even treat higher grade 2 and even grade 3 well differentiated. So how do we decide who's a good candidate or not? First of all, especially for grade 1, as you mentioned, it's usually grade 1 patients are slow growing indolent disease. So oftentimes I don't start with PRRT. Oftentimes I'll start with somatostatin analog. And that is on top of, you have some wonderful surgeons here on podium. So if it's not a resectable or a surgical candidate, so systemic therapy wise, SSA. After SSA, if the tumor progresses, again, we have multiple options. If the tumor is only progressing 1 or 2 spots in the liver, you may not want to pull the trigger on PRRT because it's a systemic radiation, so radiating our whole body. So you really need to figure out the burden of disease, bulk of disease. You may want to use liver-directed therapy, or again, targeted surgery in those cases. A stereotypical patient who may benefit from PRRT in the second line or third line would be a lot of disease inside liver, outside liver, especially even bone mets. Those are really well treated with PRRT. I've had patients who were on very high doses pain medicines, and they came off the pain medicine with the help of PRRT because it really helped with the bone disease as well, bone mets. So that might be a good candidate with a lot of disease burden, disease in a lot of areas, because the other therapies we have, the Afinitor, sunitinib, now cabozantinib, they're also very effective, but they have a lot more side effects as compared to PRRT. So PRRT makes a lot of sense in a low-grade patient, but wide distribution of disease, symptomatic disease, etc., for second or third line. Okay, some other things to confirm before we kind of pull the trigger on PRRT is you want to get a DOTA-TATE PET, and the tumor should light up on that PET. That means you have the targets that I was talking about, the somatostatin receptors. Now, by definition, a grade 1 tumor, 95% of chances they should have somatostatin receptors. It's very, very rare for a grade 1 to be receptor negative. So you almost always have it. This, oftentimes we see a problem in a higher grade 2 or a grade 3 where there could be some areas which are not lighting up on dotatate PET. That means it could have de-differentiated or is a higher grade. It's not going to respond very well to PRRT. But if you have a grade 1 disease, you've been through SSA, you have a lot of disease, not just some areas, the PRRT might be a very good option, especially if it's lighting up brightly on the dotatate PET. I hope that helps.
Yeah, that was excellent. Thank you. Building up on that question, where we're also talking about bone metastasis, people want to know, how do you tell if pain is from bone metastasis or just pain if you already know you have metastasis to the bones?
Yes. Unfortunately, when it comes to pain, some of it is you have to use the clinical judgment because it's not 1:1 correlation, right? So pain in cancer patients is a tricky situation, right? So you try to find the organic reason first of all. If somebody's telling me, "Doc, I'm hurting here," okay, there was a time where I did a CT scan, could not find, did a dotatate PET, and we found a small tumor in clavicle or the collarbone, and then we were able to radiate that, and pain went away. So if it is a very specific focal area and it's always at that particular pain, and it looks like it's coming from the bone, and you can see it on some of the imaging, like a PET scan or a CT scan, then most likely that pain is stemming from a bone metastases. And if it's just one area, sometimes external beam radiation is amazing. Sometimes even one fraction of radiation is good enough to give lasting relief from bone metastatic pain. Having said that, pain, if it's a little bit generalized, my whole back is hurting or a part of area back is hurting, and patient does have a lot of bony metastatic lesions, some of it could be bone mets and some could be not bone mets related pain. Some could be tumors impinging on the nerve roots and causing pains and radiculopathies, etc. So pain is not as straightforward. So what you need is, again, in pain also a multidisciplinary sort of approach. If it's a discrete lesion that you can appreciate on the scan, which correlates anatomically that this is where I'm hurting, radiation will be a good starting point. However, if you're continuing to hurt after the radiation, you may want to talk to your doctor. What else can we do? Oftentimes, there are different type of pain medicines. There are narcotics that are good for general pain. Then there are neuropathic pain medications that are very good for nerve pains, like gabapentin, etc. So you really need to understand what's the root cause of the pain in that particular patient. Sometimes pain stemming out from mesenteric disease or a tumor close to the pancreas may benefit from nerve blocks, in my experience. So celiac plexus nerve blocks, etc., can sometimes really help. So pain is itself not very simplistic. That one stop shop sort of treatment. You sometimes may have to think what is causing the pain, understand the nature of pain, and try to tackle it from all angles.
And somebody has asked here, can the word lesion and tumor be interchangeable? So a lot of times, I can answer this really quickly. A lot of times, the radiologist or us as physicians might refer to it as a lesion, but most of the times, we are, in this case, the way you have phrased the question, dotatate scan refers, I have a 1.1 by 1 centimeter lesion in the head of the pancreas. That is referring to the tumor based on the information I have here.
Yeah, lesion just means abnormality, something that's not supposed to be there. You can see mass. Some people will say tumor if they know it's a tumor, but a tumor is a type of lesion or a type of mass, but it's not necessarily vice versa. It just means an abnormality.
And going to you, Dr. Maluccio, people want to know how do you know which tumor is the primary?
Oh, well, so if you have something where you go to the emergency room and you get a CT scan for some other reason and there are masses in the liver and you get a biopsy and that biopsy comes back consistent with neuroendocrine. Well, then we just, for the most part, play the odds and then read the cross-sectional imaging in the context of that piece of information, which is that pathologic information. So small bowel primary can be picked up. You can either have some evidence of lymph nodes within the mesentery. You can have some evidence of there being abnormalities within the sausage part of the bowel itself. If you're looking at bronchopulmonary, you would get a CT scan of the chest without contrast, looking for a primary there. And then the pancreas can be tricky because you can have a very small primary in the pancreas with really much larger metastatic disease, and we will often then use MRIs with contrast and endoscopic ultrasound and trying to find the primary. Now, it does kind of matter. I mean, I wouldn't say that we don't treat patients with what we call metastatic neuroendocrine of unknown primary, but that our data that drives the success rate of certain therapies it can be primary specific. And so if you say, oh, the data is strongest in surgical cytoreduction, then it's the strongest in metastatic midgut primaries. They tend to be more indolent, and therefore the survival advantage is a little bit more reassuring. Whereas the data is weaker when you get into metastatic pancreatic or metastatic bronchopulmonary. And then, as was mentioned, I think by Del Rivera, is that although the odds would say it's going to be in the bowel, and then the second odds are going to be it's in the pancreas, and then maybe you'll get a type 3 gastric hypertension, and then you'll get some lung. But there are going to be times when, I mean, we all see, because we see a lot of neuroendocrine, thymic, primary ovarian. And so you have neuroendocrine cells from your brain all the way to your backside, and each of them has a different propensity to show up and or metastasize. So did that answer that question?
I think so, yeah.
Yeah, and just to make sure everybody knows, primary means the place that it started. So it's like the original tumor. So if your original tumor was the small bowel, then we call it small bowel primary. Just in case, I mean, we use some terms sometimes that maybe not everybody's heard before, but that's what that is.
Dr. Rose, for you, best suggestion to monitor or treat severe narrowing of superior mesenteric artery due to net around artery?
Ooh, yeah, that's tough. So I think if possible, have it removed. But that's not always possible. It does get tricky. Using radiation at the root of the mesentery can make it worse. There's some data that PRT also probably may not be good if you have SMA narrowing. You at least have to use it with caution and do it in a place that does it often. Dr. Maluccio is working on some experience, it sounds like, potentially with histotripsy in that, or has some interest in it. But it can be very challenging. And I think, unfortunately, a lot of times we're stuck with systemic therapy. Stenting doesn't usually work very well in my experience.
Yeah, and I'd agree. So I got into neuroendocrine actually in the area of transplant. And so we would get the base of the mesentery with encasement. And so the use to have to go in a slow growing tumor, to have to go to intestinal transplant is the only way to ultimately solve that problem. That is a very unique situation. So the question being, how do you monitor it? We will usually monitor it with actually really probably CT scan with angiography as some component of it to better determine whether or not we feel that there is any subtle changes of tissue compromise, because you worry a little bit about ischemia of the small bowel if it is consistently getting more narrowed. So surveying it is probably easier to answer than what we're going to do about it if someone ultimately starts having a lot of abdominal pain, if they try to eat, or obstructive symptoms associated with just chronic problems with that blood supply. But that historically, it has been that the only way to salvage something that is truly encasing the superior mesenteric artery is going to be a small bowel transplant. And then our program has probably been the most assertive at debulking the base of the mesentery, and is associated with a lot of complications. And so we don't take those decisions lightly. But if it's that versus an intestinal transplant, we will usually try that beforehand. We even tried that in Indianapolis when we were sent patients for transplant. We would usually try to release some of that without going to transplant, but it is very difficult, and we will usually use systemic therapy.
Dr. Shahan, this question is for you. I'm going to combine a couple of questions because it's all functional. So the first part of the question is, can a pancreatic net change types? had an insulinoma, but now have a gastrinoma 4 years later? That's one of the first functional question. The second is, even if you do not have carcinoid syndrome, can you have a reaction to local anesthesia, such as minor surgery or dental work? And can you have carcinoid heart disease when you do not have carcinoid syndrome, or you're non-functional?
All great question. The first one is a little bit of a rare situation. Typically, when we diagnose somebody with a type of neuroendocrine cancer, the functional neuroendocrine tumor, and in that category, let's say it's carcinoid syndrome or VIPoma or gastrinoma or insulinoma or glucogonoma, it usually sticks to its original characters, usually. There have been some rare instances. We've ourselves published a case report several years back. Again, this is from my days with Dr. Eugene Woltering in LSU. We had a very interesting case of grelinoma. It's a ghrelin-secreting pancreatic net, which transformed years later into insulinoma and a pretty bad insulinoma, very refractory. So that has been published, and very anecdotally similar other rare situations have been published. It's a possibility that's what's happening here, but that's not the rule. That's rather an exception. Okay, so whenever that happens, again, in our field, we always have to, keep our antennas and radars up. So if patient is exhibiting signs and symptoms, you want to investigate with the relevant biomarker. So kudos to the doctor of this particular patient. They were able to recognize and they were able to diagnose that, okay, now the gastrinoma is an issue or gastrin secreting tumor, and they were tracking that. So that's very good. The treatment management principles are relatively same regardless, right? You want to treat the tumor, you want to debulk the tumor and things and so on and so forth. So that's the number one. Secondly, Garima, refresh my memory. What was the second question?
Yeah, the question was, can you still have reactions to local anesthesia even if you do not have carcinoid syndrome? And can you have carcinoid?
And the carcinoid heart, correct. Well, this carcinoid crisis and linked to the baseline serotonin is itself a matter of debate, to be honest. Traditionally, we know carcinoid syndrome patients, these are neuroendocrine tumor patients secreting high serotonin, are at risk for developing, carcinoid crisis to certain stressors, which may cause tumors to release more. And that could be stress, that could be certain drugs, that could be certain foods. So in this particular case, we are talking about like local anesthetics, etc. And that has been the usual principle. Lately, there's some new data, especially from Dr. Pommier's group in Oregon, and they've studied it very methodically. And they have not been able to find, let's suppose, intraoperatively that patients who have large tumor volume or burden with high serotonin, that they necessarily are at risk for carcinoid crisis intraoperatively. And moreover, their thought process now is that the prophylactic somatostatin analog also doesn't really matter much. You can't really predict it. Patients with low or high, it doesn't predict. In fact, in one of their papers, they went on and said, you treat the crisis just like you would treat any other cardiogenic shock, and not necessarily as a carcinoid crisis with high dose of octreotide, etc. But having said that, that's just one school of thought, and I'm glad we have some very astute surgeons. I would like to hear their opinion about this matter as well. But the science is not very clear. I tend to be on a conservative side. So my patients who have neuroendocrine tumor and have functional neuroendocrine tumor with serotonin secreting tumor, I always try to tell them, be cautious, tell your dentist any procedures that you have this disease so they are prepared. And it doesn't hurt to give a short-acting somatostatin analog before the procedure. It's a very benign medicine. So there's nothing much to lose. So I'm on the conservative side, but just in full disclosure, the field is moving here and we don't really have full clarity about it. And the last but not the least, there we do have some good quality data, carcinoid heart disease and functional neuroendocrine tumor. So if you look at the long-term morbidity and mortality, a carcinoid heart patient has several-fold higher risk of dying from from the cancer and carcinoma heart disease if that develops. So it's very crucial for us to diagnose this soon and in fact prevent from carcinoma heart disease from developing. And fortunately, over the years, the incidence of carcinoma heart disease is declining. Okay. Having said that, patients who have very high level of serotonin, they seems to be more at risk for developing carcinoma heart disease. So if patient does not have elevated serotonin or the breakdown product of serotonin called urinary 5-HIA, they tend to be not at that risk of developing carcinoma heart disease based on the data at least. So if I have a patient whose serotonin levels are well controlled, I'm not that concerned. But patients who have very high level of serotonin, despite our maximum management, they are at risk for developing carcinoma heart disease, mesenteric fibrosis, all these complications from high serotonin. And we watch them very closely. I might do them echocardiogram once a year, some patients even more frequently based on how their valves are looking. But with low level of serotonin, the risk is certainly lower based on the data. Dr. Maluccio, Dr. Rose, what do you think about carcinoid crises and the second question regarding the dental procedures in a non-functional or non-serotonin secreting patients?
Carcinoid crisis can be very scary in the OR. So I think that when you say that something is debatable versus us saying that we aren't quite sure how to treat it, I think are two very different things. I think the fact that carcinoid crisis happens, I think is going to be a very real event. It is usually going to be people come in with carcinoid syndrome and have elevated serotonin levels. And the Palmier paper is predominantly on whether or not the ways that we are currently trying to keep that from happening actually keep it from happening. And whether or not what we use to try to treat it when it's happening is the way that we're supposed to treat it when it's happening. So those of us, like when he says we're being conservative, I think those of us look at the risks associated with the protocols that we have in place, both for trying to keep it from happening and to treat it when it's happening, whether or not that be in an IR procedure or in the operating room. Considering the number of cases that we do not see as many complications related to the sequela of carcinoid crisis than Palmier had in that paper. And so I think that what I have gotten out of that was that I'm not going to die or bleed on the hill of talking about either whether or not what we're doing is right or whether or not we should change it. I just don't think that we are going to change what we do because it's really low risk, change what we do to then potentially have issues that we currently don't have.
Yeah, I agree. I think that paper was mostly about management and intraoperative, and I have changed my practice. I don't give it, but I do kind of have the surgery, if possible, timed after they get their most recent dose of lanreotide because I don't know why not. But I think his point of that was that, and through his studies, that when he measured in the operating room the blood levels of serotonin and bradykinin and some of these other things that we know to look for at the time of a carcinoid crisis. And his definition of a carcinoid crisis is very, very stringent to the point where if you looked at his data, he's having it way more often than I have ever seen in my life. It's like every one of his patients has it or something. But I think it's only because he is incredibly prescriptive about how he does things. He has a very defined measurement of what he calls carcinoid crisis, which is probably too tight for my opinion, but he's a very good scientist. And he looked at the blood levels of these chemicals at the time where people's blood pressures were dropping, and there was no correlation between the chemicals and the event. And I think his point there was that we don't really know what's causing some of these things. I've had a patient who was flushing in front of my eyes, and I had a 5-HI checked, and it was normal, right? So there are things that are happening in this patient population that we can't explain yet. We don't know what chemical it is, so we don't know to check for it, right? And so I think that yes, it can be serotonin, but it doesn't have to be. And I think trying to target and treat these things may be helpful in the OR. I think his other paper was showing that it actually probably is not, and it delays what you actually need, which is pressors and fluid. But it's not really going to hurt. So long answer.
Well, the carcinoid heart disease is another one. So, Aman, you'd have to clarify for me. So, I can't think of a case off the top of my head where a non-functional tumor developed something that they defined as carcinoid heart disease. So, I have to have you clarify that point. But the people with carcinoid syndrome, elevated neuroendocrine markers, I certainly have had people present with their diagnosis with acute heart failure and then found to have valvular change, because carcinoid heart disease is a very particular type of valvular heart disease. And the ultrasonographer and the findings on echocardiogram are very specific for carcinoid heart disease. So it makes me think that perhaps if someone is linking some valvular problem to a non-functional neuroendocrine tumor, you may be thinking that it's carcinoid heart disease, but it's really that you're allowed to have valvular heart disease and it be unrelated to your diagnosis. So, but Aman probably sees a lot more of the medical people. So functional tumors, I have seen it in X levels of serotonin or 5-HIAA, and why it happens in someone when it's only 500 and another one when it's like 18,000. I don't know why there would be that difference in risk. So I've never really known it. If someone has an elevated serotonin level that's persistent over time, I do get an echocardiogram. I don't think I do them every year, but that I do get an echocardiogram looking for those types of things. But I don't believe that I can think of something off the top of my head where I have linked a non-functional neuroendocrine tumor to carcinoid heart disease.
I don't think I've seen.
Yeah, I have.
Right, I agree. I just want to clarify that. So what I meant by suggesting, if you look at the mortality risk from carcinoid heart disease and the elevated serotonin, these are the patients with florid carcinoid syndrome, right? They are functional neuroendocrine tumors, they have very high serotonin level, and they are at risk for carcinoid heart disease. Patients who have lesser serotonin level, they usually don't get into those complications. And I was talking about basically functional neuroendocrine tumors. The non-functional neuroendocrine tumors oftentimes don't even have that degree of elevated serotonin to begin with. There are these non-functional neuroendocrine tumors which are called secretory, but they're non-functional. That means they're secreting some serotonin, but it's not enough to give them syndrome, that is flushing, diarrhea, all these other manifestations. They oftentimes don't have that critical mass of serotonin circulating the body that leads to these complications. So I agree with you. I meant the functional neuroendocrine tumor patients. Even within those with very high serotonin, uncontrolled serotonin, are at the risk of carcinoid heart disease. Fortunately, these days we don't let patients get to that place where they have sustained elevated serotonin level. We do things like surgical debulking, embolizations, and these treatments to lower it down, to reduce or mitigate this risk.
Yeah, you brought up a good point, Dr. Chauhan. I've also had some cases where there's not been symptoms of carcinoid syndrome, but the serotonin or 5-HIA is significantly elevated, and I'm surprised that there are no symptoms present. In those situations, I think it does make sense to periodically get an ultrasound, an echocardiogram to look for carcinoid heart disease, but that happens rarely, and I'm mainly chuck it and restrict it to small bowel neuroendocrine tumors.
Well, and I would also...
And yeah, stay tuned for there is a study at MD Anderson that will be released soon called TeleHeart study, and they're studying role of telitrestat ethyl in understanding the risk factors and how to monitor it, and then of course how to mitigate those risk factors and improve the carcinoid heart disease risk. So that study, because they're not just studying echo, they're also studying pro-BNP, cardiac MRI. So we may get a little bit better understanding of how to monitor these patients and how to kind of preempt those who are going to get in trouble, etc. But I'm with you on this. I have very low threshold to do yearly echoes with patients who have high serotonin levels.
Yeah, I also have a very low threshold for treating people. So with liver metastases, which tends to drive a lot of the serotonin, I have a low threshold for treating people, even with stable disease, treating people with the primary endpoint of dropping the serotonin level and trying to decrease that risk. I don't have a stitch of evidence to suggest that that's helping, but that I feel like when you have disease, the drugs aren't necessarily going to drop it to a comfort level. And I I don't like staring at something that's well over 1,000. Like every single time you meet the person, if they're like a 40-year-old, otherwise healthy, I feel like that's a lot of life years to develop carcinoid heart disease. So right or wrong, I don't know what you guys do. I will tend to use liver-directed therapies to try to drive that number down, even in the setting of otherwise stable disease.
Yeah, I have a similar approach. If there is heavy tumor burden and high serotonin levels, I would definitely discuss that. Yeah. Now, this question is directed at me, but I would also like to hear from Dr. Rose and Dr. Moluccio. They've been doing this much longer than I have. So the question is, if a patient has small bowel and let's say a spot or two in the liver, and you do surgery, and they have no evidence of disease after the surgery, have you had instances where they have not recurred? And if they do, how long of a period have you followed them for? So, in my experience so far, if you have had small bowel, or let's say another type of pancreatic primary with liver metastasis, even if you have had surgery, there is definitely a real risk of the tumor coming back. I would say, and I'm just kind of thinking out loud, probably the longest I have seen, I do have 1 or 2 patients who have gone about 2 years where they've not had recurrence. But I would like to hear, in your experience, what is the longest time you have followed somebody and the tumor came back versus didn't come back?
Oh, yeah. So we have a really, really long database because I inherited one of the oldest programs in the country. So we probably have 25 years of data. I've definitely seen that happen. I've always been surprised that you would be able to render someone without evidence of disease and having that be durable over an extended period of time. I don't think I can probably say exactly how long it would have been. So a part of that question would be, what do you do when you are in the operating room and you render someone without any evidence of disease, but they have stage 4 disease? And the data would suggest that we would not need to put those people on adjuvant somatostatin receptor analogs because you have no measurable somatostatin receptor avid disease. And so therefore, you're going to fall into this category for which this question is relevant. And I would say that we likely have a lot more than what Gupta is describing, of people that spent years without actually having any significant clinical disease. Now, you can also put into the context on the fact that we've only had the current contemporary somatostatin receptor PETs for around 8 years. And we used to use a really crappy PET scanner, of which you never would have even picked up the disease. So a lot of the cases that would have been done like in the early 2000s or before we got this PET scan, we likely were putting them into that category when, had we had the PET scan, they likely had small volume disease. But the reality is that it can often be such a slow growing tumor that whether or not it's there or not there, or comes back in 2 years versus 5 years, depending on how close you're following them, it likely is not going to impact the fact that you're still going to live a really long time and likely succumb to something else.
Yeah, I would agree. I think it definitely can happen. The odds are against it. I mean, the chances are you're probably going to have more disease at some point in your life, but it can happen. And I hope it will happen more as we get additional systemic therapies that are more effective. I think part of that question was, how long would you follow them? I'd say at least 10 years.
Okay.
Okay, Dr. Chauhan, this question is for you. Why would an area light up on a PET scan when a tumor has not been found? That's the first part of the question. And then there is another related question. Mid pancreatic neuroendocrine tumor, 1.2 centimeters, lighting up on the PET scan. Would PRRT be a good option with no other evidence of disease?
Okay, I'll take the first one. I think second one would be a good fit for our expert surgeons here. So the first one, why does the area light up on a PET scan, but I guess the biopsy is negative, if I got it correctly?
There's no information. It just says, why would an area light up on a PET scan where I guess a tumor has not been found? So there is no evidence of tumor in that area. Yeah.
So again, okay, great question. And we see this not infrequently in our clinic. See, at the end of the day, no scans, no blood test is 100% diagnostic. all of these scans at best, even dotatate PET scan, some studies says the sensitivity specificity around 90%. That means the accuracy, and some says almost 95 to 97. But no scan is 100% accurate. So if something lights up, there's a very high chance this could be a neuroendocrine tumor, but there's always a chance it could not be. In my career, I've seen patients with hemangiomas. That means a benign blood vessel, outpouching or growth there, or inflammation. There are a lot of things under the sun which are benign and nothing to worry about. Just because it's lighting up on the PET scan doesn't mean that it is a tumor. The only way, the gold standard, is biopsy. When you sample it and you see it under the microscope and the pathologist confirms it. Okay, that's the gold standard. So there are times where something lights up on the PET scan. There are areas which are called physiological uptakes. For example, the neck of the pancreas, the uncinate process of the pancreas, and certain other areas in the body that lights up naturally. Perhaps they have somatostatin receptors in those areas, which is normal. Those are called physiological uptakes. So please don't worry if there is no anatomic correlate with that. The other times where PET scans sometimes can light up is PET scan for a real disease. For example, if somebody truly has a small tumor, it's not showing up in other scans. PET scans are very sensitive in the sense that they can pick up very small, as small as 3 millimeter disease, but it's too small that you can't really do a confirmatory biopsy, and it's nothing else is picking up. So those patients where you have a very high suspicion, but no way to confirm it, we watch them closely. We just don't let them kind of go away. So if I have a case, there's a spot in the bone, but the biopsy was negative, I'm going to continue to monitor at least till I'm assured that this is not growing or anything of that nature. But not everything that lights up on a PET scan is a tumor. That's the take-home message. And a biopsy is the gold standard to confirm, okay? Regarding your second question, well, I think it's a surgical question, and surgeons have a pretty clear guidelines in what needs to be cut out and what we can afford to monitor in terms of the size of the tumor. So I'll defer the question to our surgeons.
And I think you kind of covered that in your talk.
Yeah. I think so. For the 1.2 centimeter question, what would PRRT? Would that be a good? So, if you're asking, can you give it? Yeah, sure, you can give it. The question really is, should you give it? And I think the reason would be is because you think it's somehow risky, that it could be a risk to your life, or it's symptomatic. And for a 1.2 centimeter tumor that's not spread somewhere else, I'd say if it's symptomatic, you should probably have it removed, unless you're unhealthy. And if you're not healthy enough for it, then you still have a single lesion. So in that case, maybe standard radiation might be better than PRRT, because PRRT is going throughout your whole body, but you're really trying to hone it in on one spot. You can aim a radiation beam at one spot and give more radiation than through the PRRT. So if the reason you're not having it removed because it's symptomatic is because you're not healthy enough for surgery, maybe radiation's better. If it is not symptomatic, it's not making hormones, it's not pushing on things, then it falls in that 1 to 2 centimeter range where it's probably not going to be a problem. And we're going to recommend following it, because the operation, the risk of that is higher than the risk of this tumor actually causing you trouble in your lifetime. But we will follow it for at least 10 years to make sure it doesn't grow.
The next question is there financial support for patients with neuroendocrine cancer when insurance does not cover 100%? So it depends on what the insurance is denying to cover. Is it a PET scan? Is it a particular type of treatment? Because oftentimes I've gotten denials, and I'm sure we've all gotten denials from insurance for PET scans, and we often have to appeal and call them and do peer-to-peers and get it approved. In terms of the treatment, sometimes it can be the same thing. You just have to talk to the insurance company, advocate for your patient, and I will say most of the times we're able to get it approved. If for some reason we're not able to get it approved, our pharmaceutical companies have patient assistance programs, so we can always look into that as an option to see if we can get coverage directly through the pharmaceutical company. Of course, there are, at UABV, we have certain resources as well to try to get coverage through case managers and social workers. So those avenues are available as well. I don't know if you want to add anything to that.
No, the only thing I would add is I think that as the insurance business, it has evolved into a complicated and messy business. And so when you have an unusual diagnosis that requires subspecialty drugs and scans and things like that, is that there will be medical policies that have no inclusion. You are trying to then extrapolate from something in a medical policy, and it makes it much more difficult. And I think the question is also trying to say is it's not just about whether or not it's approved by the insurance company, but because you may choose something with a high deductible plan, you are honestly forking over a copay that is going to be $1,700, $2,000, $2,500 for that scan, and your out of pocket is ultimately upward towards $10,000 or $12,000. And so you have to be a far savvier person when it comes to even employer-based health insurance when you have a diagnosis that is going to require things that are not lung cancer, breast or prostate, where those things are almost required to be covered in some way, shape, or form. And I think that's where the exchange program, some of the Advantage Medicare, have really made it very complicated because people think they're covered. And then they realize when they get this diagnosis that they are not. The copay assistance, I think Ipsen has a very strong copay assistance for the injectables, but that is where I personally feel that we are in for some rocky road in the next 2 years on how much that's going to change and how we're going to have to try to navigate and advocate for our patients accordingly. But I do think that the companies are also probably going to step up because a lot of the companies in neuroendocrine are very committed to the neuroendocrine, and they realize that we're in for maybe some struggles.
Yeah, I think right now in this country, it is worse to be underinsured than to be uninsured. I think if you're uninsured, you can qualify for a lot of programs. They can get the covered for you. If you got good insurance, it's going to be covered for you. But if you're underinsured, you're just SOL, right? You can't qualify for the programs to get it paid for, and your insurance company is definitely not going to pony up more money just because you're sick. So it's a tough spot to be in. I had a hospital employee from one of the other hospitals in town get cancer, and her insurance company through the hospital did not cover her chemotherapy. So I had to take her straight to surgery for her metastatic disease rather than give her standard of care chemotherapy because she could not get it, wouldn't pay for it.
Yeah, we were talking about gaming the system before. We've even had people that are our patients, but we follow them, and the local oncologist is the thing. And when we weren't able to get something done, I was sort of like, well, here where we're doing it, you're going to happen to be randomly driving by our hospital when you all of a sudden have a bad attack of abdominal, I should be telling the judge, abdominal pain. And you're going to just conveniently
end up in our emergency department. Yeah.
Because if it's an emergency thing, then you don't have to get pre-authorization, and then you can't get denied and things like that. And so the fact that we have to do it, I think, is unfortunate. I promise you, Judge, that we don't do it all the time. But it is just, it is really unfortunate. And I mean, we all that have employer-based things, and you have open enrollment, and you never think, and you're like, honey, are we just doing the same thing over time? I think people with unusual cancer diagnoses have to be really, really careful at open enrollment time on what is covered. The lanreotide went off of certain Medicare Advantage plans without people even knowing it. So they aren't going to get some letter that says, oh, by the way, starting your next open enrollment, the drug that you've been on for the last 5 years for this diagnosis is no longer going to be on that formulary. So you're going to have to choose a different plan. And so if they're not going to send you a letter to warn you, and you aren't going to be a savvy consumer and read all of the things about where that plan fits with your diagnosis, then I think January is always a very, very uncomfortable time of year for us, because we won't know it until that first injection or that first PRT or that first thing comes up, and then it's problematic, and we're having to try to do it all in retrospect.
Okay.
Dr. Gupta, I just want to make a quick comment. I agree with my colleagues here. One thing I want to encourage the patient or the listeners here, I don't think we talk enough about out-of-pocket costs and financial toxicity in oncology and general medicine in general. Don't be shy to discussing these matters with your oncologist. Many times I've felt that patient doesn't tell, they're shy. They'll think, what would the doctor think, or they may not offer. please be upfront. There are times where our hands are tied and we can't do much, but there are times where we can really help advocate and find. For example, there've been times where my patient was paying more out of pocket copay, and then I just figured out, okay, we were out of not network, and I found another doctor where they could just do it at a much cheaper cost, and I can still continue to see the patient, but they're getting drugs somewhere else. So there are a lot of different things. So just be upfront about your financial toxicities with your doctor and see if they can help and pull some resources through social work, or sometimes pharmacists in the clinic have some great ideas how to circumvent some of these costs.
Thank you. All great thoughts. So one question here is, I have paraganglioma, and my oncologist refers me to specialists for different issues I'm having in my body, but those physicians are not familiar with paraganglioma. Where do I go from here? So I think for this, your doctors need to be really talking to each other. If you are being seen for another issue and you have, let's say, metastatic paraganglioma, which is stable, I don't know the details, but if you're not at risk of any other, whatever treatment you need, there needs to be communication between your doctors. I don't know how many times I've spoken to people at, within the institution or outside because they're not familiar with neuroendocrine tumors, or but in those situations, I would just recommend the doctors to talk. And on the last note, open to all three of you, any opinions on holistic therapies and nutritional considerations for neuroendocrine tumors?
I was giving you that question.
So for holistic treatments, I think it depends on what type of holistic treatment we're talking about, right? I know there is a lot of buzz right now about ivermectin, febendazole. We get asked about that a lot. In clinic, I'm sure all of us have been asked about that. What I say is we don't have any evidence. I mean, so far, the entire day, we have talked about so much evidence in clinical trials that we are basing our treatment decisions on, right? And if somebody can show us that these drugs are active and they work based on scientific literature, we, of course, are not going to withhold any treatment that is going to be effective. In terms of other holistic treatments, acupuncture, massage therapy, all of that, as long as it's being done in a safe way, if it feels like it's going to help you, I don't see an issue with that.
Yeah, I'm really into it. I went to Berkeley. I'm totally crunchy granola. So I think that holistic is making an assumption that it is somehow a naturopathic method, and I think that the fact that we have licensure in naturopathic medicine would suggest that although we don't talk about it a lot, there's clear-cut evidence that those things help. I think when you're combining naturopathic or alternative methods or additional methods or complementary methods with Western methods, then like everything, we need to know about it because there may be combinations, and those combinations are not going to come up on our EMR as being a high risk for a bad reaction. And then if I were to give my 2 cents about ivermectin, that is not even remotely holistic. So we might as well just take the holistic outside of taking poison. So it may be a different type of poison, but it is a poison. It may kill cancer cells, but so does chemotherapy, a different type of poison. So where we have seen 2 of our patients succumb to complications of it is when they were too nervous to tell us that they were doing it. And then I have a poor wife of a 38-year-old asking me whether or not the likelihood of his going into liver failure was because he was combining ivermectin with his cisplatin etoposide. And I said, I can almost guarantee you that is what ultimately led to his acute. Yes. And so we've lost 2 patients, and I feel like it was because they didn't want to ask us about it. But I'm just one of those vocal people that can't even believe we're having a conversation about whether or not we should be making ivermectin over the counter, which we can in Louisiana now, because it is a poison. I mean, it is not a holistic, it is not naturopathic. It is also a treatment, and it's not even really a treatment that is used commonly in the United States of America. And so I feel like it is just foolish for us to be making it available, especially if you have people that are not going to tell us that they're taking it because they're getting it over the counter.
It's a deworming agent, yeah. So is albendazole. So yeah, these are just you give it to animals, but you also give it to people. It's more commonly used in Africa, where some of these helminthic worms are endemic, which actually can be in the South too. So there are in these GI gut worms that can be in the soil here, but it's used for a very specific thing, and it is a medication, and it does have side effects, and it does interact with things. I've seen a woman have a horrible Stevens-Johnson syndrome from it, where she lost all the skin on her body. She had 90+% of the skin slough off her body, and it was absolutely horrible. So it can happen. It is not a benign drug. It should not be given over the counter. That's absolutely ridiculous.
It also should not be misinformation online as being an alternative naturopathic medicine. I think that's where I think the health system is speaking up, is that I think that how it's being, like kind of like history, how it's being, the narrative is suggesting that it is a less toxic, less morbid naturopathic medicine. And you're just like, no, it's just a medicine like everything else that's not really a proven benefit in what it is you have.
Yeah, and if you're getting it from wherever and it's not through a pharmacy, you question how pure it is, what you're even getting. And I think I'm from California originally, and I believe in complementary medicine, and I think it can help a lot with symptoms. And every drug, well, most drugs we give had some sort of origin in
Taxol.
yeah, exactly. From the yew tree, it had some sort of natural origin. People use these words chemicals. We're giving well, yeah, everything's a chemical. We're chemicals, right? The thing the glass on your table is made of chemicals. But the thing in plants is that there's thousands of them, and maybe a few of them do have an effect against your cancer. And so as a scientist, our job is to find out which two chemicals in that yew tree is the one that's having an effect. And then we figure that out, and we synthesize it, we purify it, and then we can give it to you in a form that we know the exact dose of. And then we can do studies to know if it has an effect. And so I think that there are probably plants out there and supplements that you can take that may have an effect that we just haven't figured out yet. I'm not going to say that they're not going to, but the problem with the over-the-counter dietary supplements is they're not regulated. They can come from anywhere. The FDA has no approval process over them. Nobody's screening them. I've seen a number of studies where independent companies take a whole panel of vitamins or whatever, and they measure, how much of milk thistle is actually in this pill. And 80% of these companies, there's like negligible amounts. It's mostly just a sugar pill, right? Or sawdust or something from China. So I'd be very, very cautious about these things. And the biggest thing is just talk to your doctor and tell them exactly what you're taking, so that if there is a known interaction, then we can at least work with you on it and help protect you.
Yeah, and I'm really into juicing, I have to admit. So I think that there are things that can make you feel better. For people that have a lot of fatigue associated with neuroendocrine, I've told patients that smaller, more frequent meals and probably having a Vita-Water, something that you're sipping on over the course of an entire day, kind of like a marathon runner that tries to take things every couple hours to sort of keep them going. And then for people that are truly interested in naturopathic medicine, I think Memorial Sloan Kettering at one point in time had an entire thing on their website, and we called it it was run by a PhD, and we called it like the quack versus the real. And you can click on almost any other thing. So you could have clicked on milk thistle or green tea or whatever it was, and they had already vetted everything for you, and they would have said, okay, this was tested in these cancers, and there was some benefit, or it was safe, or this, and then this. They say, oh no, we tested this, and you cannot use it if you're on this regimen for this type of a cancer because there's an interaction. So they did a lot of the vetting for you. But to take green tea as an example, that was well studied, and there was an association with improvement in certain cancers, like maybe colon cancer. But the concentration of green tea, I mean, you'd be green. like drinking that much green tea. So they now have supplements of concentrated green tea. So it's not like you can't take advantage of the things that truly have been tested, but that you just buying a whole pack of green tea is probably not going to give you that benefit. But personally, if it's not going to hurt you and it helps you have control over your situation and gives you more energy and makes you feel better, like you're doing something about it, well, then I'm like, amen, sister. You know, that'll at least be the one thing that you can control. But there are avenues out there. And I would say I thought, and that was probably around 15 years ago. My prediction is it's still up. It may not be upgraded as much as it is, but it wasn't. My prediction is that ivermectin's probably going to be on that list on the MSKCC site that would tell you all the reasons why you should try not to.
Yeah, and I think eating healthfully is always a good idea, and it's very hard to eat too much of a good thing. It's very easy to take too many pills of some weird pseudoscience, right? So you can overdose on vitamins. You can overdose on a lot of these supplements and cause irreversible side effects. It's pretty hard to drink so much green tea that you're gonna or eat so many carrots or something that you're gonna overdose on vitamin A.
Yeah, fat soluble vitamins. If you wear a heavy amount of weight, you can definitely get vitamin toxicity from fat soluble vitamins because you'll store it in your fat stores. And so I think that if you're going to go the naturopathic route, just do as much research as you would before you are going to start a chemotherapy. But I think that there are definitely going to be resources there. And I think for neuroendocrine, whether or not, we all follow Ronnie Allen, but I think that there are some people trying to give really good advice on how you can eat better or eat smarter or do something that is not going to certainly not harm the treatment that is going to be required.
Yeah, and be wary of anybody who is telling you how great something is and then also happens to be selling it on their website. Right?
Hey, have you seen my website?
That was fantastic. Thank you. Thank you, everybody. And I'm going to turn it over to Marianne.